Second point, cooperative federalism. Cooperative federalism programs have been around for a long time. What they do is they induce states to follow federal priorities by encouraging them with financial incentives. Under Medicaid, typically for our state, it's not quite 2 to 1, but I'll use the word 2 to 1. It's roughly 2 federal dollars for 1 state dollar. Now this is hog heaven for politicians at the state level on the way up, because for every dollar in tax revenues or every dollar it's spent at the state level, you get $3 worth of program. So this is great. You pay $1, you get $3. Who could be against that? Sounds wonderful. Until the $1 becomes very expensive. As I like to say to my students in the health law class, think of whether if Bill Gates decided to give you his house, a $38 million house, free with the stipulation that you had to pay the property taxes, the insurance, and keep the upkeep. Is that a good deal? You got a free house, but you have to pay the property taxes, the upkeep and maintenance, and you have to run it and pay the repairs. Is that a good deal? Well, at some level, it's a good deal. But for many of us, the expense of running a free house and paying the insurance and the property taxes and so forth and the maintenance would not be such a great deal. It becomes unaffordable. The good deal becomes a bad deal because even your small share of the outcome of the expenditure becomes onerous. And that's what happened. That's what drove the 10-care reforms 5 and 6 years ago, is that our $1 became too expensive for the state to bear, even though it was a good deal that we were getting $2 in federal money beyond our $1. So that's cooperative federalism. I've argued that this is a form of political narcotic because on the way up, it's easy to get hooked, but on the way down, it's extremely painful to have withdrawal. And why is it extremely painful to have withdrawal? And it's extremely painful because the arithmetic works in reverse. For every state dollar you save, you lose 3 program dollars. And so on the way up, it's wonderful. You're on a high. Those endorphins are flowing. On the way down, it's excruciatingly painful. You're there withdrawing because you're losing 3 program dollars for every dollar of state funds that you save. Now, federal policymakers understand this dynamic, and President Obama is probably the most sophisticated in this regard that we've seen in the modern period. Healthcare reform is premised upon building on this notion of cooperative federalism. Medicaid will expand, and Governor Bredesen is projecting, depending on whether it's the Senate bill or the House bill, anywhere from $700 billion to double that, $1.5 billion, in state dollars over a 10-year period, which will basically necessitate either driving out many other state priorities or broadly increasing taxes at the state level, including possibly an income tax. And so how does this work? Under federal constitutional principles, cooperative federalism is permitted because the Supreme Court has been very permissive on allowing federal government to create financial incentives and create conditions on the receipt of those financial incentives. Basically, the federal government can bribe the states to fare thee well. And if the states are bribed or bribable, then they can receive those dollars, and the Constitution places very, very limited, and at this point entirely theoretical, limits on the ability of the federal government to induce states to participate. But the states do have a weapon, and that is that the federal government, under our cases, cannot force the states to participate in these cooperative federalism programs. In cases going back to 1990, New York versus United States, and later Prince versus United States, the Brady Bill case, the Supreme Court has announced what it calls the anti-commandeering principle. The federal government cannot force, it can bribe, but cannot force the states to embrace a federal priority. So what does this mean? That if the state expenditures become too extreme and Medicaid becomes a bad deal, it puts tremendous impetus on the states to just opt out of Medicaid. Now, this is unthinkable in the current context. No state seriously would think about this. Every state has Medicaid. Arizona was late to the party, but all states have Medicaid. And why do states have it? It's unthinkable to ask poor people to bear the full cost of their medical coverage and not to have the state absorb most, or if not all, of the costs of medical care. This is a norm, this is a value that we all share, widely shared. I certainly endorse that principle. But under health reform, the federal government is going to put money, subsidization, for poor people. And so this changes the landscape. It makes opting out of Medicaid, which was unthinkable before, thinkable now. Because poor people who are on Medicaid can then go into these national exchanges that are being proposed and get subsidized with federal dollars, and the state can save its money. And if the deal that the federal government is putting forward is not generous enough, the states can subsidize poor people from within the state to purchase on these exchanges. This is something that the federal government hasn't even thought about. This is something I'm putting on the table. You may have seen the interview with Uton Ward in the newspaper. I've put this forward. I won't say the exact scope of this, but this is something that we need to talk about. It becomes politically viable if people who are now on Medicaid have the ability to receive benefits, but at the federal level. And this is something that the federal government hasn't contemplated. So the law and the policy give states this leverage, and if the deal becomes too onerous, this is an opportunity that the states can avail themselves of, and the federal governments are indefensible. Federal government does not have a defense against that, and that's something I'm working on. I will now shut up, and I will introduce Todd Gaziano. Todd, do you want to come up and speak from here? Thank you very much.